Okay, so thank you guys all so much for being here. This is our sixth Perspectives in Global Health session. We're really excited to have Dr. Benjamin Anderson here today. And thank you to some other participants who are joining us. And now for everyone here, I'm going to give a brief introduction to Dr. Anderson. So Dr. Benjamin Anderson is a professor emeritus of surgery and global health medicine at the University of Washington. He was a surgical director of the UW Breast Health Clinic and cared for patients with breast health issues and diseases from 1994 to 2020. He was also the American Society of Breast Diseases president and vice chair of the National Comprehensive Cancer Network Breast Panel. He's also worked in international global cancer control for over 25 years with joint appointments at Fred Hutch and the UW Department of Global Health. He also chaired the Breast Health Global Initiative program, which pioneered the development of resource stratified guidelines in low and middle income countries. So that's what he's going to be talking about with us today. So thank you so much, Dr. Anderson.
Well, thank you very much. That was first, I'm really pleased to be able to be here with you today. The Binaytara Foundation, I'm really impressed at the work that you've been able to do. And I'm glad to contribute and by providing some background of the work that we have done. Back in the late 90s, a group of us at UW became interested in global oncology and how to address breast cancer in low and middle income countries. The Breast Health Global Initiative was supported at the Hutch and UW, and we developed these resource stratified guidelines. The 3 years of 2020 to 2023, I worked for WHO, and we launched the Global Breast Cancer Initiative and its framework, and that's what we'll be talking about today. And the concept here is, how do we develop a framework that functions? How do we make this work in settings where you have some but not all of the standard pieces that are available? Breast cancer is the most common cancer diagnosed globally, and that's taking men and women together. It's the most common cancer among women worldwide, and there are more disability-adjusted life years lost to breast cancer than any other malignancy among women. There's this common concept, misconception, that breast cancer is really just a problem in high-income countries. Actually, the majority of breast cancer cases and deaths occur in low and middle-income countries today. And this gap is widening. By 2040, 60% of the projected 3 million new breast cancer cases and 70% of the 1 million new deaths will be in LMICs. If you look at 5-year survival, there's this huge range where 5-year survival in high-income countries, North America, Western Europe, greater than 90% 5-year survival, but it's 66% in India, 40% in South Africa, which is probably closer to what is seen in Nepal. And while this is a clear statement of disparity, it is also a statement of opportunity, because it shows that we actually do know what to do. The question is, how do we do it in settings where that don't have everything that we have established? But if you think specifically of sub-Saharan Africa, keeping in mind that the population is younger, half of the breast cancer deaths occur in the women under the age of 50. And for every 100 deaths in that young age group of under 50, 210 children lose their mothers to cancer, become maternal orphans. So the impact here is truly significant. It's not just a familial or social problem. It's not just an economic problem. It is a generational problem. And that's why we have to be talking about this today. Here you see the incidence of breast cancer globally, looking at IARC's GlobalCan data, and you can see why this idea that, oh, well, breast cancer is really just in these high-income country settings. That's because of the dark blue. What we forget about is that how we detect the cancers has a lot to do with this. And when we do screening, when we do early detection, when we look, we find. And so it increases the incidence. But if you change the question and ask, what is the #1 cancer among women? Breast cancer is the most common malignancy among women in 86% of countries. If we then look at mortality, we see, well, gosh, the mortality rates are the most dramatic in sub-Saharan Africa and the poorest regions globally. But if you ask, what is the most common cause of cancer-related deaths? Breast cancer is #1 or number 2 among women for mortality in 95% of countries. And so the concept here is that no Ministry of Health can overlook breast cancer if they want to talk about cancer as a public health issue. It's too big. And that's why this very much is a problem and a current problem. Okay, so now stepping back, ideally we would prevent cancers. And so if we know risk factors for breast cancer, they include being overweight, particularly in postmenopausal women, and obesity. Alcohol is the single most powerful modifiable risk factor. About 5% of cancers globally are attributed to alcohol consumption. Physical inactivity, exogenous hormone use, these are those factors that we look at. But if you ask the question, okay, if we could fix all of these things and get everybody to be fit and exercise and do all those things that we need to do, that would influence about 20% of breast cancers. So it's not the majority that would be affected through primary prevention. Therefore, we need to go on. And the question is, if we cannot prevent cancers, then you have to go through this sequence of early detection, prompt diagnosis, and treatment to completion. And therefore, the question for us from a health systems perspective is, how do we support this in ways that are functional? And what can we learn from the high-income country environments that are there? Recently, we published a study of looking at the Global Breast Cancer Initiative framework, which we will be talking about in greater detail later. But these are 21 Asian countries. And isn't it interesting when we look at mortality, that the highest mortality rates down to the lowest mortality rates, look how variable incidence is. So, and what that gets to, it's unlikely that the biology is different between these countries. This has to do with the health system. And the more early detection work that we do, in particular with screening, the more cancers we're going to find. But that does not immediately translate to a parallel mortality piece. So the story is a little more complicated than we would have thought of. If you then ask the question, okay, well, what are the features of health systems that can improve breast cancer outcomes? That we did an analysis when we first launched from WHO, the Global Breast Cancer Initiative, and we asked the question, what characteristics of health systems are associated with reduced breast cancer mortality? There were 2. One was higher degrees of universal health coverage, or stated simplistically, paying for it. When we have funding, that is one of the common features. If there's no funding for it, it's unrealistic to think that the health systems are going to magically make things improve. And the other factor in multivariate analysis was number of public cancer centers per 10,000 cancer patients, or stated simply, access. We need access and we need funding, and those are the common features that are associated with increased breast cancer survival in those settings. Here we see those 21 countries, and you can see that there's a distribution, a linear relationship between 5-year survival and improvement in cancer early stage detection. And that's a very important feature, as we'll talk about later. Similarly, when we look at universal health coverage, how does universal health coverage correlate with distribution, early stage disease? We also see an improvement. So the paying for access, having access is associated with improved early detection, which links to those findings. All right, so what do we do with this data? How do we actually make this happen? Here in this graph, this is breast cancer mortality in 10 countries. And that pattern that we saw in the US between 1990 and the present time has been a common pattern among these successful countries, where breast cancer mortality was reduced by about 40% between 1990 and the present time. And the question is, how do we then translate that finding into low and middle income country settings, some of which, but the small minority, have actually seen those improvements. So translating those findings is therefore the key issue. But we've, for 20 years, we've been talking about this, and yet very little has changed. And perhaps the issue here is we haven't been answering the right questions. So how do we then rethink our questions so that we can develop approaches that are practical and realistic? So if we look at the high-income country guidelines from NCCN, ASCO, or ESMO in Europe, they're real problems because they have not, in the past, they didn't look at resource allocation. They just said, here's ideally what would you do? So first question is, what do you do when the systems are limited? Then the next question is, all right, so how do we adapt so that in these settings of limited resources, and Nepal would of course be a great example, and therefore what features of the health system characteristics will have meaningful potential to improve breast cancer outcomes and more broadly women's health? And the really frank question, is it even possible? Because when we started doing this work in the early 2000s, and we were going to sub-Saharan Africa, people said, why are you doing that? Because the thesis being, we just don't think you can get there from here. And that, I think, has been one of the major limitations in thinking this through. So the Global Breast Cancer Initiative that WHO launched is based on the principle of doing what it is that we did in North America and Western Europe, broken into 3 phases. Early detection, how do we find the cancers when they're early enough? The second interval, diagnosis, who has cancer and who does not. This pillar is often overlooked. And then that third pillar of treatment, and how do we do this? If you do the math, if we were able to reduce breast cancer mortality by 2.5% per year globally, that would change the outcomes for 2.5 million women. Over a 20-year period, we would be saving 2.5 million lives. This is a worthy goal. And that idea of 2.5%, those reductions that we saw in North America, those were between 2 and 4% per year. So this is not an artificial number. This is a real number that actually has been achieved starting in the 1990s using tools that we would consider standard today. So that first pillar, early detection, that one of the places we really got stuck was this discussion of screening, because screening was the big argument. Do we screen? And if we screen, when do we start? And while that may be an important question in high-income country environments, this is not the major way in which patients get in. It's usually because they're presenting with a clinical symptom, a lump or a finding in the breast. Once we have an abnormality that identified through one of these methods, then we need to move them onto that second pillar to then do the diagnostic workup. But the target that was identified by WHO is for at least 60% of invasive breast cancers to be stage 1 or 2 at diagnosis. That's the threshold. So then you ask, great, where'd you get that number? Where's that 60% from? When we did that analysis of the 141 countries, this is the same publication, we found that 35 countries out of the 141 had adequate both mortality data and stage distribution data that we could identify where they stood. 20 of those had that sustained mortality reduction of at least 2% per year for at least 3 years. 15 of them did not. And when you looked at the stage distribution, all of the countries that had that reduction had at least 60% of their cancers being stage 1 or 2. Conversely, we have not found a country yet where the distribution was worse than that and they still achieved improved breast cancer mortality. So it gives us a target, as opposed to arguing about, do you do mammographic screening? Can we buy mammographic equipment? We're instead stepping back and saying, what is the threshold that the country needs to get to? And that's the information the Ministry of Health needs. Here you see the distribution of by stage of cancers in these different countries. China is one of the examples, and you can see that it appears that they cross that 60% threshold. So the purple and the blue lines are that threshold. But you have to remember, when you collect the data, you have to consider the patients where you don't know the stage. If you only look at the referral centers, stage distribution might look a lot better than if you looked at the group of patients that didn't make it. So not knowing your stage distribution is a big gap. Or looking at it numerically in this publication, while it may seem that China and Malaysia and the Philippines, all of those countries, they have at least that distribution. If you then take into consideration the unknown patients, not knowing their distribution, and they may well be more advanced patients, now you don't know that you've crossed that 60% threshold. So what's the message of this? Knowing your cancer staging is an essential component of addressing health systems issues, because it tells you, do I really need to be focused on early detection? Is treatment where I am? Where's my gap? And that it's a very important data point that is often not available or easily collected. Indeed, when you look at the US and mortality, we started doing early detection work in the early 1980s because it was the late 70s that the screening studies were published and showed that mammographic screening improves outcomes. It was actually about 8 years, 9 years later that's when we started to see mortality improve. So you also have to remember, when you do early detection, there's a delay before the survival changes will occur. And that's normal. That's actually what our data shows us. If you take this from a modeling perspective, CISNET does cancer modeling. And when they looked at this in breast cancer, this was back in 2005, but the point that they made was, yes, early detection may be essential to improving outcome, but it has to be linked to treatment. If you don't also have treatment, if you just do screening, you're getting them bad news sooner, but you're not going to impact on outcome. And so looking both at early detection and in screening is fundamental to improving this outcome. And what I'm getting at here is this is relevant to all of the solid tumors. We're using breast as the example, but look how breast is an index for the other adult cancers, and because the same patterns need to be addressed. Mammographic screening, as we've been talking about, this has been a huge topic. And for those that have followed the screening literature, this graph might be familiar, this figure. What it's showing is the improved survival that we saw, approximately 20% improved survival over that period of time through screening, and that was in women 50 to 69. So this is very standard data that argues for this. What was really interesting was the exceptions are the two Canadian trials that you see in the middle. And so when the Canadian trials came out, they actually did not see the same outcomes that we saw there, and we'll touch on that. But you also have to keep in mind, when we talk about screening, screening is for a certain age group. We don't screen everybody. The evidence for mammographic screening is for women ages 50 to 69. And if you soften your criteria, there's reasonable evidence for women in their 40s, particularly 45 to 50. The evidence that mammographic screening works for ages 40 to 45 is very limited. And you have to remember, younger women have denser breasts on average. And so do we just screen younger because the population is younger? That's not a good strategy. And because mammograms don't work better just because your population is younger. And you also have to remember, when you screen, you get false positives. And remember that bar graph that we had before. Just because you found a bunch of cancers doesn't necessarily mean it's going to work. We saw this in prostate cancer in the US. PSA screening did not shift the mortality curves, which is why we don't do it routinely. But going back to the Canadian trials, the Canadians have published this repeatedly, and they now have 25-year follow-up in their randomized trial in which women were randomized to mammographic screening versus not mammographic screening. And for at least 2 decades, everyone's been throwing rocks at the Canadians saying, well, obviously you must not know how to do a mammogram because everyone else seemed to make this work. But if you delve into their data and you say, okay, you got the mammographic arm and you have the control arm, how big were those cancers in the control arm? Actually, the median tumor size is about 2 centimeters. So from a global health perspective, the question is not, could the Canadians do a mammogram? The question is, what were they doing in the control arm that wasn't randomized to mammographic screening? Because if we could get down to 2 centimeters in Nepal, we'd be doing well. That would be a really powerful piece for us. All right, it skipped forward. Let me back up. So one of the questions then is, well, if you're doing screening in Canada, but you're not doing mammographic screening as that first step in Canada, what were they doing? Was it clinical detection? Because that seems obvious. And for 2 decades, people would say, we don't know if clinical breast exam shifts mortality curves. And if it doesn't shift the mortality curve, did it matter? Then maybe we shouldn't be doing it. That changed because of this trial that was published out in a few years back out of Mumbai. Women were randomized in India to clinical breast exam versus education alone. And then they followed them doing this repeated every 2 to 3 years. And what they found was that not only did they successfully downstage or stage shift by using clinical exam, they were able in women 50 and above to cross that 60% threshold. And in fact, if you look at the bottom graph, they actually documented a mortality benefit. Remember, it's not the screening that improves outcome, it's the treatment that improves outcome. And as you know, it's not easy to treat patients in India. And so we do now have evidence that clinical staging in that setting where women present with very advanced tumors, this works. This is important. So the second pillar of the framework is prompt diagnosis, because if you find women who have 10 women who have a lump in the breast, lumps are very common, 1 out of 10 will be cancer, 9 out of 10 will be benign. You have to be able to do a diagnostic workup in a reasonable period of time. This is very standard. Clinical evaluation, standard imaging with mammography and ultrasound. Actually, ultrasound is the one that's important for palpable masses. Tissue sampling and pathology. How do we standardize this? The target that we identified was you need to be able to make a diagnosis of the cancer patients within at least 2 months. The rationale being that it takes 3 months where you start to see treatment at survival outcome differences. So this was based on a standardized review of a systematic review of all studies of delay in breast cancer detection. Of those 87, there were 38 that had adequate data to look at 5-year survival. And what they found was that if delay was longer than 3 months, everybody longer than 3 months, 12% had a lower 5-year survival. If you were able to confine that to 3 to 6 months, it was a 7% survival. So that 3-month point, that's why 3 months is important. We want to be starting treatment within 3 months, and that would be true in Nepal as well. How do we get our system set up so that that works? That's the big topic. And when we were looking at this in those resource stratified guidelines, what are key issues? Well, patient and family education, human resource capacity development, these were all very important. But that third category, patient navigation, how do you navigate the patient through the system so that they can make it in a timely fashion? What we had suspected at that time, this was published back in 2008, that this should improve screening rates if we can navigate the patients effectively. It should improve adherence to treatment protocols, and you should improve patient satisfaction if you're addressing this in a culturally sensitive way. And now we've got data supporting this. In Colombia, which is an upper middle income country, in Cali, which is one of the cities that my group City Cancer Challenge is working in, that there were analyses of use of navigation. They had noted that in Cali, accessing programs was difficult. There were a lot of administrative delays because of how their healthcare system is set up, and there was poor communication between the hospitals, too siloed. And when they introduced navigation, what they found was that they could reduce the waiting time for biopsies, the biopsy to diagnosis time, and the diagnosis to surgery time. All of them could be improved through the use of this. So I have to say, in the work that I've done, I used to think, oh, it's the technology that's so important. Oh, it's the fancy drugs. Actually, being able to navigate correctly turns out to be a really valuable and important piece in what it is that we're doing to address health systems fragmentation, which might be one of the most universal features of health systems, including our own. And indeed, their data look at the improvements that you can see by virtue of the navigation pilot they did in Cali. In the United States, you would reference that you're interested in underserved communities in the US as well. Here we have a study out of Chicago published in 2020 in which they were navigating to do this diagnostic workup. And what they found was, in comparison to historic controls, that they could make very significant improvements in completing the diagnostics, and even in the younger age groups, and that they found that they could really navigate much better and achieve these outcomes that were significant. So this is not just low and middle income countries. Most recently, published earlier this year in Malaysia, they used a navigation program in the community for early detection, and then nurse navigation on the treatment side. And in introducing this, they found that all of these points, ultrasound time, time to biopsy, communication, surgery, neoadjuvant therapy, all of them were improved through the use of navigation. And treatment adherence even was improved, which is relevant to the third pillar that we're about to start to talk about. So my point here is sometimes the interventions are much simpler than you would think, and it's not just about buying fancy equipment. Now, treatment. Now we've made a diagnosis. How do we treat them? And this is very well worked out. We know a lot about how to use surgery, radiotherapy, and drug therapy. We know a lot about when you do the surgery first versus when you do the drug therapy first. And these are all very standardized approaches that one can look up in the NCCN or ASCO guidelines. The target that we identified for this is treatment completion, of treatment without abandonment. And I'll show you data about why is that important? What difference does it make? Why does that matter? But we also emphasize this point about supportive services. So in a lot of settings, the ministries think, okay, I need to get those drugs, and we need to get and they think very much about the cancer-directed therapies. But if you don't have supportive care, the patients won't follow through. So consider the idea of getting chemotherapy, but you're not getting medicines that help you to not throw up, which that was the problem in the 1950s, 60s, and 70s, is that people felt so sick during treatment. Why would they continue? So the key thesis here is that supportive services, whether it be medications, psycho-oncology, lymphedema management, physiotherapy, these are not optional services. They're required to get you through the treatment components of this. Okay, so how do we do this multimodality treatment? This is how we set up multidisciplinary care. We use patient navigation, and key issue, this is really important to the work in Nepal, I believe. You have to measure your outcomes. If you do things and then later figure out, I wonder if it made a difference, you will have great difficulty identifying whether you were measuring, whether your interventions improve outcome. So it's like building a car and not having a speedometer and a gas gauge. It's very short-sighted to not have a gas gauge, because when you need to know when you're going to run out of gas, and building it before you run out of gas and putting it in the dashboard is probably a pretty good idea. But we don't forget about the patients after they're done with treatment. They have to return to their communities. They need supportive services there. So you can see this is a very comprehensive, thoughtful, systematic approach to how we do health system strengthening. But what about this point about abandonment? What is this, and why does that matter? The ABC-DO study in sub-Saharan Africa, the African Breast Cancer Disparities and Outcomes Study, was a cohort study done in 5 sub-Saharan African countries, where women were first identified as having cancers. They were interviewed by a nurse, and they were followed over time. And one of the things that we found from the ABC-DO study was, gosh, the countries in sub-Saharan Africa are not all the same. In fact, they're different even within countries like Namibia. And it makes a difference where you are. Sub-Saharan Africa is not one big country. It is much more heterogeneous. But if you look at the averages, that lower right-hand bar, what you can see is that of those patients that started treatment within 3 months, and unfortunately that wasn't everybody, but of those, only about half, this is the orange pie, only about half of them finished. That's the worst outcome one can imagine, because that means you used the medicines, they got the side effects, but they didn't get the clinical benefit, because it's not the first dose of chemo that matters, it's the last dose of chemo. Did I make this all the way through? And treatment completion is not particularly easy to measure for technical reasons that we need to do. And it's going to depend on our system as to how we're going to measure this. But if we look at that sub-Saharan African data and look at the 3 pillars, if the blue bars is 3-year survival across the board, and it's really pretty lousy. But if you can improve the treatment, if you can stage shift to achieve that 60% outcome, and if you can create access, survival goes from this very poor outcome to a much more reasonable outcome. The proof here, the point here is it's worth it to be doing this work. And yes, we have the right framework for thinking of limited resource settings. But policy making that by the government, they don't just listen to the clinical community. In fact, I think they more often ignore us than rather than pay attention. And civil society, what does the public believe? They are the gas in the gas tank. They're the ones that drive this. And policymakers, certainly in an electoral system, are more likely to listen to the public than they are to the providers. So thinking about health system strengthening, what are those services that we need? We need to form partnerships in order to do this. This is where WHO is going, recognizing that breast cancer is not a silo. Breast cancer is an indicator for systematic improvement. And if we can do breast cancer, there are a lot of cancers that we can do. And therefore implementing in alignment with those 3 pillars, looking at training, looking at data collection, looking at improvement in outcome through navigation and other techniques, this is how we're going to impact globally. But when we implement that, Kenya is asked for an analysis that the World Bank provided for, and we worked with the collaborators that happen to be Seattle-based RTI International. We work with them to develop an economic model. This is currently in press. But and this is also relevant to Nepal, that when you start advocacy to say, we want to improve outcomes, you create demand, you have to do training, you have to deliver the services, and then you have to measure your outcomes. Here's the data from the model that you need to remember. If we, in Kenya, which would be fairly similar, I would think, to Nepal in terms of distribution, the first 5 years is just spent getting set up. It's making you ready to do early detection. Then if you screen, whether it be with mammographic screening, that's the best outcome, or clinical screening following what was done in India, you can achieve those 60% outcomes. But this takes 5 to 15 years to implement. When you do breast cancer, this is not a short-term investment. You have to be thinking in the 10 to 15-year framework. The ministries need to understand this, that's what's going to happen. So in summary, breast cancer we see as an index malignancy for improving outcomes because it helps develop systems for optimizing resource-appropriate strategies for early detection, diagnosis, and treatment. Those 3 pillars, early detection, prompt diagnosis, treatment to completion, it defines a roadmap based on the patient pathway. By thinking of that early diagnosis, mammographic screening is not the starting point. Clinical detection is the starting point. And the question is, do we get to screening down the road? You don't build the penthouse when the foundation is not yet built to get to that 60% threshold. Patient navigation is a vital tool for being able to improve these outcomes. Using the framework and implementing navigation in measurable ways, this is a key strategy. That modeling that we talked about, I showed you the model. There are cost pieces that go with that now the Kenyan government has to look at. Overall, we think that the GBCI framework is a catalyst for change because we're developing generalizable approaches that are relevant not just to breast cancer, but to all cancers and actually to all non-communicable diseases for women. It's really a fundamental strategy for improving women's health in the global setting. Thank you very much for your time and attention.